Good evening, welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ. Tonight we're talking about the latest breast cancer trials and research. Before we get started, some housekeeping. If you have any technical issues, there should be a phone number in the chat box at the bottom left of your screen. You can enter the password, which is also on your screen, to talk to an assistant. Or you can type details of your problem in the chat box and our support team will be in touch. Any sound problems, you might prefer to listen on your phone while watching on your computer. You'll see instructions how to do that in the chat box too. You can use the chat box during the webinar to ask questions, which hopefully we'll have time for later. And you can also actually chat to other people who are watching. Don't worry about missing out on information while you're chatting. The webinar is being recorded and will be available on our website in the next few days. As you probably know, there's a ton of breast cancer research going on around the world, but tonight we're focusing on recent developments that might be of real interest to New Zealanders now or in the near future. We have three panellists who are going to share with you tonight. Dr Anna Bashford is an oncologist, Vivienne Maidens and Sarah Munro are breast nurses. First, we're going to hear from Anna Bashford. She's an oncologist at Auckland Hospital specialising in breast cancer. And in June, Anna attended one of the largest breast cancer research conferences in the world, ASCO, in the USA. That's where many of the clinical trial results are reported, and Anna's going to share with us the ones that she found most interesting and most relevant to Kiwis. Anna, thanks so much for being here tonight and for being willing to share with us. Tell us what you learned.
Thank you, Adele. Well, it's my pleasure to talk to you all tonight about the latest breaking research from the ASCO conference held in Chicago in June, as Adele said. First of all, I'm going to touch on metastatic breast cancer and look at the trials that were presented in this area, focusing on, first of all, the estrogen receptor positive subgroup, then the HER2 positive subgroup, and then a really interesting study looking at patients with BRCA mutations. And then finally we'll move on to early breast cancer and again break it down into the subgroups of HER2 positive disease and estrogen receptor positive disease. So first, in the metastatic estrogen receptor positive early breast cancer group of patients, we have a very exciting family of drugs called the CDK4/6 inhibitors, and two examples of these are palbociclib and abemaciclib. And we know that this CDK4 pathway is intimately involved with the estrogen receptor pathway, and that this may lead to endocrine resistance in some patients. So the concept is, could we add a CDK4 inhibitor such as palbociclib together with our endocrine therapy and try and improve outcomes for patients? And that's what they attempted to do in the Paloma-1 study. And this was a study in patients with advanced breast cancer, which was estrogen receptor positive and HER2 receptor negative. And patients were given the aromatase inhibitor letrozole plus or minus the study drug palbociclib. And at 30 months of follow-up, this trial showed an improvement in progression-free survival in favour of the combination with palbociclib of 10 months. They also looked at overall survival, but this wasn't the primary endpoint, and this showed a trend to an improvement of 3 months, but this wasn't statistically significant, and really we need more time for this data to mature, but it's a really exciting start, and there will be more studies also with this drug in this setting that we look forward to. Again, another family member from the CDK4/6 inhibitors is a drug called abemaciclib, and this was looked at in another study called Monarch 2, again in patients with estrogen receptor positive HER2 negative advanced breast cancer, but in this study patients had progressed on a previous line of endocrine therapy such as tamoxifen or an aromatase inhibitor, and patients were randomized to receive fulvestrant, which is an estrogen receptor antagonist, plus or minus the study drug abemaciclib. And at 20 months of follow-up, the study showed again an improvement in progression-free survival, this time of around 5 months. So again, that's very exciting, and we'll see the curves from that study with progression-free survival on the y-axis and time on the x-axis, And you can see patients in the group receiving the study drug abemaciclib with a blue line with an improved progression-free survival. So this is also a very exciting study. So the take-home messages from these two trials are that abemaciclib and palbociclib may be used first or second line together with endocrine therapy in estrogen receptor-positive advanced breast cancer. The two studies we've looked at have shown an improvement in progression-free survival, but no overall survival benefit has been seen yet, but it's really early days and there's more research coming in this area as well. What we don't understand best yet is how to sequence these drugs with our endocrine therapy agents such as fulvestrant, and also whether these drugs may have a role in other types of breast cancer such as estrogen receptor-positive, HER2 receptor-positive breast cancer. And excitingly, I think for us in New Zealand, about a month ago, palbociclib was registered here, but it's not funded, so it comes at a cost of around about $5,900 to patients, so it's very expensive. That's for a month of treatment. So next we're going to touch on the HER2 positive metastatic breast cancer setting and look at a really interesting study called the Alternative Trial. And this is a study looking at whether we could actually do away with chemotherapy altogether for some patients. It was a first-line study in the HER2 positive, estrogen receptor positive metastatic breast cancer setting. And it looked, at the moment our standard therapy is trastuzumab or Herceptin and an aromatase inhibitor. But what would happen if we added another HER2 targeted agent such as the drug lapatinib? And there were 3 patient groups. In the first arm, patients received 3 drugs, lapatinib, trastuzumab and an aromatase inhibitor. And the second line, our standard of care here in New Zealand, trastuzumab and an aromatase inhibitor. And in the third group, lapatinib and an aromatase inhibitor. And this study showed an improvement in progression-free survival of 5.3 months in favour of the 3 drugs. And there was also a trend to an overall survival benefit for the 3, but this hasn't met statistical significance yet. And I think we've got the curves there showing again progression-free survival on the y-axis and time on the x-axis, with the top curve there showing the benefit in favour of the 3 drugs. So the take-home messages are that there may be a role for dual HER2 targeted therapy and endocrine therapy in patients who can't tolerate chemotherapy, and we need more studies again looking at these combinations. What about in the very difficult treatment group, the metastatic triple-negative breast cancer setting? The Keynote 86 trial was presented at ASCO, and this is a study looking at the new immune agent pembrolizumab or Keytruda in the metastatic triple-negative group of patients. And the cohort that was presented at ASCO was quite heavily pre-treated with chemotherapy, and it was a study really just looking at pembrolizumab as a single agent to see whether it was safe and clinically active in this group of patients. And you'll see in the table on the left that there weren't a huge number of responses, but there were some patients that responded and some that had stable disease. And within these groups, some patients actually had a very durable response to the treatment. And in the right-hand table, this is patients who'd had no previous treatment, so as we'd expect, there were more responses. And I think overall, this is an exciting study for these patients, and we really need better markers to pick which patients are going to do well with this drug and this family of medicines. And finally, in the metastatic setting, there was a really exciting study presented in the plenary session, which is kind of the ultimate at ASCO. And this was in metastatic breast cancer for patients with BRCA1 and 2 mutations, a study called Olympiad looking at a PARP inhibitor versus standard chemotherapy in patients with HER2 negative metastatic breast cancer and a BRCA mutation. And basically, this study showed an improvement in progression-free survival of 3 months, and there was no difference in overall survival. But within this study, the group that got the biggest benefit were those with triple-negative breast cancer. And this study is so significant because this is the first trial in breast cancer showing a benefit in favour of a PARP inhibitor. So the take-home messages of metastatic breast cancer and triple-negative disease, pembrolizumab and other similar drugs may provide a treatment option, but more research is coming and is needed. PARP inhibitors such as olaparib are a targeted treatment option for metastatic breast cancer patients who have a BRCA mutation. And we need further research looking at the perfect timing of this drug with chemotherapy, and in particular our platinum-containing agents such as carboplatin and cisplatin. Well, what about in the early breast cancer setting? First of all, we're going to talk about a study called Affinity. Now, this is a trial looking at the drug pertuzumab that has been shown to have a significant impact in the metastatic setting, so the logical thing has been to see whether it has a role in early breast cancer. And this was a study looking at chemotherapy and trastuzumab and pertuzumab or Perjeta for women with early breast cancer versus the standard of care chemotherapy and trastuzumab alone. After 4 years, the women taking the pertuzumab had an improved invasive disease-free survival of only 1.7%. This was statistically significant, but it was a small benefit. However, when you sort of delve further into the study, it seemed to be the patients with larger tumours, lymph node positive tumours or estrogen receptor negative tumours that had the greatest benefit. The biggest problem here is cost, and one discussant stood up and said it would cost $500 million to save one recurrence. So while it's an important study, that has to be balanced into the equation. Next, the ALTO study is looking at whether one anti-HER2 agent is enough or whether we could get some extra benefit by adding a second. So it looked at adding lapatinib to trastuzumab and whether it was best to give these drugs together or one after the other. And the study reported that there was an improved disease-free survival after 7 years of 85% versus 82% in favour of taking lapatinib and trastuzumab together. And interestingly, again, the benefit was greater in the estrogen receptor negative group. And finally, in early breast cancer, a study looking at de-escalating therapy was the short HER trial. And in this study, it was a study of early breast cancer that was HER2 positive, and patients were randomized to receive either 9 weeks of trastuzumab and chemotherapy or our standard of care chemotherapy and 12 months of trastuzumab. And this showed a similar disease-free survival at 5 years and no difference in overall survival. However, there was fewer cardiac side effects seen with a shorter course of Herceptin, as you would expect. However, patients with larger tumours or with a lot of lymph nodes involved seem to benefit from the longer course of Herceptin. So our take-home messages here: 1 year of trastuzumab remains the standard of care. We could consider adding other HER2-targeted agents such as pertuzumab or lapatinib, particularly in high-risk disease, but this is very expensive and there's been no overall survival benefit seen yet. And it may be reasonable to give a shorter course of Herceptin for patients, particularly with cardiac issues or maybe even with low-risk disease. And just to finish, this is not from ASCO, but it's still an interesting sort of update, looking at aromatase inhibitors in estrogen receptor positive breast cancer. There's been one study in estrogen receptor early breast cancer showing in addition, additional benefit for an extra 5 years of the aromatase inhibitor letrozole after 5 years of tamoxifen, and then a further study looking at adding another 5 years of letrozole on after that to see whether we could further reduce the risk of breast cancer coming back. Then some more studies were released at the end of last year which didn't confirm the benefit for this approach, and in fact there were more side effects, as you'd expect, with the longer duration of an aromatase inhibitor, which again, it's like everything in life where we need to weigh up upsides and downsides. So again, the benefit of extending treatment on is likely to be greatest in those with a higher risk of disease. But I have to say, I think many oncologists, including in New Zealand, are being very, very selective about which patients we recommend 15 years of endocrine therapy for, and it's really important to weigh up the side effects of treatment and patient preference as well. So if you have any questions about that, I would recommend talking to your doctor. I hope that's helpful, Adele.
Great, excellent. Thank you so much, Anna. Now we'll hear from Vivienne Maidens. She's a breast nurse here at Breast Cancer Foundation NZ. Vivienne joined us quite recently from the UK, where she worked at the renowned Royal Marsden Hospital, among others. Vivienne, all those new drugs that Anna's talked about, are they available here? And if not, what happens if a patient's oncologist thinks a new drug might be good for her?
Oh, very good question, and thank you, Adele, for the introduction. Now, Anna has just updated us on the best of the ASCO clinical trials from June this year, but the question is, what does happen in New Zealand and how can patients access these medicines? Are they funded here or available on a clinical trial? And if not, what is the cost of these medicines? So I'm also going to talk about 2 clinical trials that we presented at ASCO this year, which showed that scalp cooling significantly reduced hair loss in women receiving chemotherapy for breast cancer. I will talk a little about the final outcome and conclusions from these 2 trials, and also what is the significance of this for New Zealand women. So just to start with, I would like to just outline the role of MedSafe and Pharmac here in New Zealand. MedSafe decides which medicines and devices are safe and effective, and Pharmac decides which medicines are government funded. Now, a doctor can prescribe any medicine that is not MedSafe approved or funded by Pharmac. So how can patients have access to new medicines in New Zealand? I will at this point just mention that all of these medicines are horrifically expensive. Though if you have insurance, some insurers will cover some or all of the costs. Deciding whether or not to fund treatment yourself can be really complicated, and it's something you really need to work through with your oncologist. The cost of the medicines discussed this evening are all on screen, so I'm not going to actually quote you all the costs, so you'll be able to see on the screen as they come through. Now, Anna has already talked about palbociclib, which has been used in trials for estrogen receptor positive breast cancer in the past few years. Palbociclib is approved by MedSafe New Zealand in June 2017 for metastatic estrogen receptor positive and HER2 negative breast cancer. It has been given with an AI, example letrozole, as first-line metastatic treatment. If there has been progression following first-line treatment, fulvestrant, which has been mentioned, would also be recommended. Palbociclib and fulvestrant are not Pharmac funded, and there is a trial that is opening up soon here in New Zealand called Patina. Palbociclib, yes, the trial for palbociclib is called Patina. That is opening up also in Australia, and also one site here in New Zealand around October for patients with metastatic estrogen receptor positive and HER2 positive breast cancer. And registrations for this trial should open in about 1 month. Abemaciclib, as Anna also outlined, in the trials for estrogen positive breast cancer, is not yet FDA approved in the USA. However, it has been awarded priority review, and in July 2017 this was going to be at the top of the list. Now, for estrogen receptor positive and for HER2 metastatic breast cancer, it is not yet approved by MedSafe New Zealand, though there is a clinical trial starting in Auckland, Waikato and Palmerston North in the next few weeks for patients with high-risk early breast cancer So they're patients with cancer that has spread to their lymph nodes and is also very large or aggressive. So moving on now to lapatinib, which Anna has also mentioned in a trial for patients with metastatic HER2-positive breast cancer. This has been approved by MedSafe in New Zealand and also Pharmac funded for metastatic breast cancer, but only as first-line treatment. And so it's not for patients who have already had Herceptin for their metastatic disease. Keytruda, the next slide. This has been approved by MedSafe New Zealand and is Pharmac funded for metastatic melanoma currently in New Zealand. There is a clinical trial running in Auckland using Keytruda for metastatic triple-negative breast cancer as first-line treatment. Though it is very expensive, as you can see, with the cost worked out depending on the patient's weight.
So Vivienne, I was just going to give a bit of an update there. I was at a clinical trials conference in Australia last week and they talked a bit more about Keytruda for the triple-negative patients. And the conversations there really backed up what Anna has already said about it. When you're looking at a drug that's expensive and it's not really working so well for patients in the second or third line of treatment, that's really something you would need to be really cautious about. The results were much better in the first line, and for me, one of the really interesting conversations was with one of their top oncologists there who probably has more experience with Keytruda than anyone else around there. And she was saying that if her patients had just been diagnosed metastatic triple negative, and if their cancer hasn't spread too far, and if their tumour is showing good immune features, and it's quite a few ifs, but in that case she is recommending it as the best treatment, along with, at the same time as chemo, along with chemo as the first line treatment. So it's very interesting.
Also, I think quite good to add that this medicine, Keytruda, they usually have it as one infusion every 3 weeks, and patients and oncologists usually know within 12 working weeks whether it's worth it. So Lynparza, or olaparib, is for metastatic breast cancer in those who have BRCA mutations, like the trial Anna mentioned. This medicine is approved for MedSafe, by MedSafe New Zealand for ovarian, fallopian tube or primary peritoneal cancer, but it is not Pharmac funded. So there are breast cancer trials running in Australia using Lynparza, and they do say that this medicine is generally well tolerated. Perjeta, we've talked a little bit about Perjeta tonight already, but currently this medication has been Pharmac funded and has been free for metastatic HER2-positive breast cancer since January 2017. For those patients with large or aggressive early HER2-positive breast cancers, the ones that Anna mentioned, they have benefited most in the Affinity trial. There are 2 self-funding options available here in New Zealand. One, there is a subsidised neoadjuvant treatment for aggressive HER2-positive early breast cancer with Perjeta and Herceptin, or there's the shorter 12-month course of Perjeta with Herceptin and after surgery. Actually, that's not shorter, but that is a 12-month course, sorry. So, what should we take from all this? We need to remember that clinical trials are free, but there are strict eligibility criteria. Now, for more information, if you do want to have more information, all these check our clinical trials database. So the address is written there on the slides. And also remember to talk to your oncologist about any of these trials, or you can also discuss them with the trials coordinator. So what happens if your oncologist thinks you might benefit from a medicine that is not funded or approved? It makes no difference whether a medicine is unapproved and not funded or approved only for another disease like Keytruda is for melanoma, or a medicine is approved for breast cancer but not funded like palbociclib. In all these cases, the Medicines Act allows your doctor to prescribe any medicine for their patient. If your oncologist thinks you might benefit from a medicine that is not MedSafe approved or not funded, what needs to happen and what patients would need to do. Always speak to your oncologist first. The oncologist would write a prescription and gives this to the patient, and then takes the prescription to the pharmacy and pays for the prescription. Prices vary, so you do need to shop around. All pharmacists charge differently. Overheads, such as credit card fees and clinic fees, can increase the cost significantly. And medicines are not returnable. So that's all about our clinical trials. I just want to add a little bit now about scalp cooling treatment to prevent hair loss. The two new SA studies were presented at the ASCO meeting on prevention of hair loss. They were using the Orbis Paxman scalp cooling machine. These were the first randomized clinical trials in the world. However, there have been many observational studies around the world which have all shown excellent results. So study one that was presented at ASCO showed that 2/3 of patients had less than 50% hair loss when using a taxane-only chemotherapy regime. Study 2, half of patients had less than 50% of hair loss when using a taxane and anthracycline-based chemotherapy. So we can see that taxane-only chemotherapy patients is much better. Study also showed overall there were significant improvements in quality of life for women, as alopecia or hair loss, although not permanent, is by far the most traumatic and distressing side effect of chemotherapy. So this next slide just shows you a picture of the Paxman machine. You can see the Paxman machine is attached to a hat. It looks like a helmet. It has a long hose that is attached to the cooling machine. There's a thin membrane inside the hose and inside the helmet for the coolant to be transported from the machine once it's turned on. The hose is detachable from the cap, and this allows the patient to get up and have a short comfort break if needed, and it doesn't affect the temperature of the cap, so that the coolant keeps the cap stable. I'm really excited and pleased that the New Zealand Breast Cancer Foundation here in New Zealand is funding a pilot study in Nelson using this machine. It's for the woman undergoing chemotherapy for breast cancer. This has been approved by the Ethics Committee, and the pilot study will be commencing in September 2017. As mentioned previously, the latest studies from ASCO using the scalp cooling system have shown great improvements in quality of life. However, some things need to be considered. So scalp cooling adds considerable time to chemotherapy sessions. It starts 30 minutes prior to chemotherapy infusions and continues up to 2 hours after chemotherapy infusion is completed. It is very cold, but most people do get used to it after about 20 minutes. Patients need to ask themselves straight away, first up, can I stand this hat on my head for up to 4 hours? It does help to wrap up in warm clothes, have a blanket handy, and a cup of hot tea helps as well. So it also can be difficult to integrate into a therapy unit, especially if it's busy. You may need extra staff on hand to help with the whole process. And it is important to make sure that patients are fitted with the right size hat. It's got to fit very snugly onto the head. So staff skill does make a real difference to the resulting hair loss. So Staff and patients need to be prepared. There are some things patients and staff can do to improve chances of success, and I've put together a list of top tips that will be placed on our website for those who are going to use Scalp calling. Thanks.
Great, thanks a lot, Vivienne. Our last speaker tonight is Sarah Munro. She's another of our breast care nurses here at Breast Cancer Foundation, and she'll be a very familiar face to those of you who are members of our MyBC online community. Sarah, we've heard a lot about research into new drugs tonight. You're going to tell us some news that's not about drugs.
On a bit of a lighter note, thanks Adele. Tonight I'll be giving you an overview on a couple of studies that were presented at the latest ESCO meeting. The first study is on electronic symptom reporting, which helps extend survival. The second is on improving nail health during chemotherapy. And lastly, I'll touch on a study on a product to help prevent skin reaction from radiation therapy. This study assesses patient-reported outcomes for symptom monitoring during routine cancer treatment. Symptoms are very common amongst patients receiving chemotherapy for advanced cancers, but can go undetected by doctors up to half the time. There is a growing interest in integrating electronic patient-reported outcomes into routine oncology practice for symptom monitoring. The trial was conducted in America and took place over 3.5 years. All patients had metastatic cancers, including breast, and were randomly assigned into 2 groups. Group 1 used a web-based tool to record symptoms, and this group was the patient-reported outcome group. When this group reported a severe or worsening symptom, a self-reported email alert was triggered to the nurse who was responsible for the patient's care. Group 2 had normal care, which involved discussing symptoms during appointments or phoning a nurse between appointments. Both groups reported on 12 common symptoms such as nausea, vomiting, pain, and so on. The normal approach to symptom monitoring, or Group 2, involved patients discussing symptoms during their clinic appointments or phoning the clinic between visits for concerning symptoms. These appointments involved complex discussions about the patient's treatment and side effects, squeezed into a very limited time. This can be challenging for doctors to assess all patient symptoms. Other disadvantages that came about were patients forgetting symptoms or not writing down all symptoms between appointments, patients' reluctance to contact the clinic, thinking medical staff may be too busy, or unsure if they needed to report a particular side effect. For patients using the electronic self-reported symptom monitoring, the following process occurred. The patient recorded and reported their symptoms using a web-based system via computers or computer kiosks at the hospital and in real time. Doctors received symptom reports and nurses received email alerts when symptoms worsened significantly. The medical team would then make an assessment of these changes, and the following interventions could be actioned. Calls to provide symptom management counselling, advice on supportive medications, chemotherapy dose modifications, referrals for imaging, or immediate admission to hospital. Trial results showed that patients reporting treatment side effects using electronic symptom monitoring were actioned and alleviated more efficiently and effectively. The study reported a better quality of life, fewer visits to the emergency room and hospitalisation. Patients who used web-based symptom monitoring were also able to tolerate chemotherapy longer and had 5 months longer overall survival compared with patients who received normal care. To date, New Zealand has not implemented a nationwide electronic reporting system to record patient symptoms. However, the Breast Cancer Foundation has developed MyBC, which is an online community for New Zealanders affected by breast cancer and new supporters. Through MyBC, patients can record symptoms and treatment side effects, track energy levels and general wellbeing. The reports generated through MyBC can be shared with medical professionals via email or printed out and taken to clinic appointments. Patients can also access Breast Cancer Foundation's nurses, Vivienne and myself, either via phone, messaging or video calls. MyBC offers New Zealanders with breast cancer an online community where you can connect with others and share your experiences and get support from qualified breast nurses. And the details will be on the slide. Also presented at this year's ASCO meeting was the trial using a plant-based nail balm for patients undergoing chemotherapy to help reduce the effects of onycholysis. As a result of taxane-based chemotherapy, patients get a loosening or separation of the fingernail or toenail from its nail bed, and this is called onycholysis. It causes pain, distress, disfigurement, infection, and restricts patients' daily activities. The randomized trial was carried out in the UK. Patients who were going through chemotherapy were divided into two groups and asked to rub a balm into their nail bed 3 times a day. The first group used polyphenol, which is a natural balm made with rich essential oils and plant-based waxes. The second group used the traditional petroleum balm. The results showed that patients using the plant-based balm had far less chemo-related nail damage and improved nail-related quality of life. For your information, this product is called Polybalm. The website where you can access this product is showing on your screen now. The cost is approximately $62 US, so that would be about 83 New Zealand dollars, and patients need to apply it 3 times a day. Although it has a shelf life of 2 years unopened, the recommendation is to use it within 8 weeks of opening, especially in those on chemotherapy. It is also recommended that you do not use the same tube for the feet on the hands, as this may transfer fungal spores. Finally tonight, I thought I would share with you a product called Strata XRT. Now this is a gel to help prevent skin reaction from radiotherapy. There are 3 phases to the skin reaction that occurs during radiotherapy. The first phase is erythema, which is just the redness of the skin. This progresses to dry desquamation, which is dryness, itchy, scaling and peeling. And finally it progresses through to moist desquamation, which is more severe. This is when the skin blisters and serous drainage occurs. Fortunately, this is not common practice for breast cancer patients. However, these side effects can lead to discomfort and distress, in particular moist desquamation, and it also poses the risk of infection and great pain. Currently, most radiation units will be applying Mepitel film during radiation treatment, and this works well and is proven to reduce the skin reaction significantly. However, these dressings often need to be reapplied by the nurse during the course of treatment and can sometimes be a bit uncomfortable. Strata XRT is a flexible gel that also helps prevent skin reaction. It dries to perform a protective layer which prevents the early symptoms of radiation dermatitis, significantly reducing skin's acute inflammatory response, and provides relief of redness, itching, discomfort and pain. Several case studies have been carried out around the world and the results show overall improvement to quality of life. Whilst using Strata XRT, patient reported reduced itching and pain symptoms while undergoing radiation therapy. Most recently, there has been a pilot study in Australia and the preliminary data shows promising results of Strata XRT, particularly for the prevention of erythema. The advantages of Strata XRT: patients can apply it themselves. The gel offers ease of use, it's transparent, and no dressing changes are required. Patients can apply it at home, it's not sticky, and it is suitable for sensitive skin. A 50-gram tube will last the whole course of treatment, and Strata XRT is not currently funded in New Zealand, so patients will have to pay for it themselves. You can purchase it from the House of Aesthetics, who have stockists nationwide, and a 50-gram tube will cost about 200 New Zealand dollars. If you do mention the Breast Cancer Foundation, they'll give you a 10% discount. So just finally, a reminder that with any new product or drug, please go and discuss it with your medical team.
Great, thank you so much, Sarah, and thanks to all of you. We're now going to open up to some questions from you guys at home. You can type questions in the box at the bottom left of your screen, and we'll get through as many as we can in the time available. So first up, we have a question. Do you know if fulvestrant will be Pharmac funded anytime soon, as it has been MedSafe approved for many years? I wish we knew.
I wish we knew. I mean, Vivienne, you would have been at the Maidens too, and we used a lot of fulvestrant there. I would love to get my hands on that, but I have no idea. I don't know whether you know. I think one of the problems in New Zealand is we did used to have access to it, and patients could pay for it. And I guess that's still the case, but a lot of my colleagues have used it as a sort of third or fourth line endocrine therapy and have been a bit underwhelmed, but when you've worked somewhere else and seen the results, and the trials actually speak for themselves, and the Monarch study where it was given second line, I think it's a great option for patients. So I think there have also been issues over the years with the 250 milligrams versus the 500 milligrams, which is better, the higher dose. So I'm not sure. Do you know anything about the funding situation?
I think so. Yes, certainly it's on those lists. On the list of drugs that are funded in places like Australia and the UK, and not here, which we think is absolutely not on, and it's a subject we do raise with Pharmac regularly. I think, Anna, like you say, there's been sort of a bit of under excitement about fulvestrant in recent years, but I think these new trials that are combining it with other drugs are going to lead to a bit more interest. So I think it's quite timely now for us to be following up to see what the plans are to fund that. We're not aware of any plans right now, but it really is an area that that does need immediate addressing.
It's one of the top issues now, together with the CDK4/6 inhibitors such as palbociclib, which we'd also love to get funded. I think that fulvestrant's right up there. It is funded in Australia, and I think those are the drugs that we can look at and say, well, hang on a minute, we're
why not?
The kind of poor cousin here, and why not? So
and another question on that matter: can one get a non-Pharmac medication like fulvestrant or palbociclib prescribed by oncologists working for DHBs, or do you have to go privately to get that kind of thing?
Or no. So the answer is yes. I only work in public, and I have a patient taking palbociclib at the moment, so it's been really exciting for her that it's become funded so recently. And it's not an issue for oral medications or injected medications such as fulvestrant. I guess in the public system where we have to look at resource implications with IV treatments, and that becomes more difficult. So sometimes with the intravenous treatments, they need to be given in private, but for oral medications there's no barrier. And then the only thing that did occur to me when we were talking before was not all pharmacies will have immediate access to these drugs, and so that's another thing. But I don't see a problem why pharmacies won't be able to order things in once we know, and if someone's stable on a particular dose. But definitely the Grafton pharmacy at the hospital has, in Auckland has palbociclib now available for patients.
So is to get it, pertuzumab, is that oral or is that an infusion?
Infusion, but that's okay in the metastatic setting. That's, I mean, there was a while there where it wasn't funded by Pharmac, so that's only a recent thing this year in January. But we just need the time to discuss it and make sure we have the staff to cover our day stay, which is pretty much bursting at the gills most of the time. So there are sort of resource implications like that. But for a while we had some patients receiving pertuzumab in private, then coming to the hospital to get herceptin and their chemotherapy, which were funded in public. So we had that situation going on for a while. But now that it's funded by Pharmac, then it's obviously offered in
but someone paying for it for early breast cancer, would they be able to get that infusion in public?
That would need to be discussed with their oncologist and then with our breast team and then taken to the whole consultant meeting. And I think that would, at the moment, it starts out on a kind of case-by-case basis and then move forward from there.
Okay, question for Sarah. Is Strata XRT more effective than fatty cream?
It is. The studies have shown, there was a study done in Australia where they were using the fatty cream, very aqueous sort of cream, and so not only was the fatty cream not that practical to be applying, Strata XRT proved to be a lot more efficient and effective.
And a question about taxanes, which you mentioned as patients having taxane-based chemo benefiting more from the scalp cooling. What are taxanes?
They are the epirubicins and the doxorubicin, sorry.
Yeah, the taxanes are docetaxel and paclitaxel, also known as Taxotere and docetaxel, Taxotere, and then there's paclitaxel. That's right. Which is Taxol, and then so the other group that you're talking about, adriamycin, epirubicin, and the anthracycline. So they got some benefit, but not as much as the taxane.
A lot of
long way.
Oh, ridiculous. Yeah,
I know. Yeah.
And so, how many people tend to get those problems with the nails?
The majority of patients actually going through having taxanes once again, because the chemotherapy will target your fast-growing cells, so your hair, your nails, and this is where the discoloration will happen. Often some patients will not get it as severe, so you'll get ridges developing, but other patients, most will get a real darkening colour.
And in terms of the radiation skin problems, what percentage of patients get those?
Look, I don't know the percentage, but most will develop the first phase of the skin coloration, the redness developing, and this is what we've found that the Strata XRT really does benefit patients from going down that track as well.
Okay. And a question about unfunded drugs. Is it okay to bring them up with my oncologist, and how should I do that?
Yeah, I think it's very important that patients do, and I think we always welcome discussion. I guess from the doctor's perspective, it becomes difficult because these drugs are so expensive, and so we have to be, that makes us a little bit cautious about recommending them. And some of the studies that I've presented where there's only a very tiny benefit, say for example, with pertuzumab in the adjuvant setting, it's such a tinsy benefit for such a huge cost. It's difficult to know, how important that's going to be for an individual patient. So I think, definitely, I think all oncologists would be very happy to discuss it. That's part of our job.
Okay, and why are so many of the trials for people with advanced cancer and not early cancer?
Yeah, I think that's a very good question. So in the advanced breast cancer setting, it's, I guess, easier to show a benefit. You have patients with breast cancer in organs, for example, you can see it shrink or not shrink, and it's easier to measure a benefit. In the adjuvant setting, survival, depending on which subgroup of breast cancer you're talking about, survivals are up above 90%. So, and then you have chemotherapy and hormone tablets, endocrine therapy. And so actually you're getting down to just such small percentages. To show a benefit, you need thousands of patients, and that's very expensive. So at the moment what happens is drugs tend to be proven in the metastatic setting, and then that leads to the question, for example, with pertuzumab, if it's so good in that setting, could we see a benefit in the early breast cancer setting? As time goes on now and outcomes are better and better, it's harder to show that benefit. You have to treat thousands of patients, which makes it very expensive. And so now there's a lot of work looking at, are there better ways, again, that we could predict which patients are going to get the benefit, for example, with kind of genetic fingerprinting of tumours, and trying to be a bit more targeted about how we recommend treatment. And obviously the triple negative group is a big group of unmet need as well. A lot of focus going on that group.
And one for Vivienne, is the scalp calling going to be introduced elsewhere other than Nelson?
Oh, I'd love to say it was, but we don't. There's a pilot study in Nelson, so we'll wait and see. It really depends on the DHB, each individual DHB, whether or not they're going to be able to afford to buy the machine, and then support. Yeah, and then they need also somebody to service the machine. It's a very important part of offering scalp cooling.
And I understand maybe a lot of nursing time.
Yeah, it does. It does take nursing. I have had a lot of experience with the Paxman cooling machines, and we actually use volunteers to help with the whole process, and that was fantastic. Really, really, really great having them in, and they just looked after the patient so well. It freed up some of the nurses.
I think, for example, in Auckland, there's real interest in it.
Yeah.
So it's the cost of the machine, it is the nursing care because we're just so stretched, but also the space and issues like that.
Yeah,
and,
it's got to be a bit of a planned.
Yeah, it is, but I think it is kind of the way things should be heading.
And hopefully we'll see good results in Nelson, and that will help other DHBs see the way that they could go ahead and make it.
There's definitely benefits for the patient. There is definitely benefits for the patient, and it's really, really great for patients to have the choice.
Yeah. So, yeah, I think that's all our questions now. Just a nice message to Anna. Huge thank you, well, to all of us, but Anna, you were this lady's oncologist, and you helped her be a survivor with your kind and compassionate care. Thank you.
Oh, thank you. Very kind.
That's very good to hear. Yeah. And yes, Anna was on our medical committee for a while, and she just had too much going on to keep going, and she's been a huge help to us. So thank you all at home for joining us tonight, and thanks again to Anna, Vivienne, and Sarah. We hope you found this helpful, and we'd appreciate if you could take time to give us your feedback as you exit the webinar. If tonight's discussion has raised any questions or concerns, you can call Sarah or Vivienne tomorrow on our 0800 BC nurse line, and you should have that number on your screens now. As well as answering questions, Sarah and Vivienne can provide referrals to our free counselling and funded rehabilitation programs, and can help you connect into MyBC, the online community we've talked about a little bit. You should also have a link for our clinical trials database there if you want to find out more about that. And if you look at that, you'll see you can get in touch with us through that as well. In the next few days, we'll send you a link to the recording of this webinar if you'd like to watch it again or recommend it to someone else. Thank you again for joining us. Good night.